atypical subhepatic acute appendicitis also. The patient presented with acute right quadrant pain. Ovarian cyst also may be missed for ureteric colic. Other differential diagnosis, appendix in the normal side in the right iliac fossa also may be missed for ureteric colic. Meckel's diverticulum, inflammation of the Meckel's diverticulum also can be mistaken for ureteric colic. Any bowel condition like intestinal obstruction or even colitis, or in general every intraperitoneal abdominal condition should be excluded before we proceed in the diagnosis of ureteric colic and before we decide that the patient has a ureteric colic. And after the initial management of ureteric colic with the diclofenac injection or buscopan injection, whether we give him fluid or not, we should proceed into the final management of ureteric colic. Actually, most of the ureteric stone will pass easily down to the bladder and the patient will get off from the stone by urination. About 85% of the patient who experience a colic in the ureter due to ureteric stone will pass easily and will pass within the time down to the bladder, and only 15% of them will need a surgical intervention. But before that, we have to know where is the stone and the size of the stone, and also we have to know the function of the other kidney. After we complete our initial treatment in the emergency ward, maybe in the same day or even in the next day, we send the patient for definitive diagnosis, radiological investigation in order to get a definitive diagnosis for the stone. What is the study that we can depend on it? We have to study intravenous urographin and also CT scan. But for the doctors, we prefer to do spiral CT scan with non-contrast. We call it native CT scan, which consider one of the most important modality for diagnosis of ureteric stone. Actually, the CT scan has the ability for diagnosis every stone in the ureter, with the exception of one stone. We called it the indinavar stone, that happened due to antiviral agent that given to the patient with acquired immune deficiency syndrome or AIDS. So spiral CT scan or native spiral CT scan consider one of the most effective method for diagnosis of a ureteric colic. What is the benefit of the CT scan? The CT scan actually can give us an information about the size of the stone, about the site of the stone, about the severity of the obstruction and the degree of the obstruction, and also give us a hint about the condition of the contralateral kidney. And actually, before sending the patient for intravenous urography or CT scan, we send the patient for checking of the renal function test by blood urea and serum creatinine, and I will tell you why in the next few minutes. So after we did a CT scan for the patient and after we did an intravenous urographin for the patient, we should proceed to the next step, which is the final management for him. The final management of ureteric colic is the conservative strategy. What is the conservative strategy? It means that we give the patient chance for up to 2 weeks. 2 weeks in order to pass the stone, whatever this size of the stone. As we know that the internal diameter of the ureter is about 5 millimeters, and so the stone, that every stone below than 5 millimeters I can expect to pass easily, but the stone more than 5 or more than 6 millimeter or even 1 centimeter, I expect that the stone maybe will be sludged or maybe impacted in somewhere at somewhere in the ureter. But this is not a rule, because even bigger stone, more than 1.2 or more than 12 millim or more than 1.2 centimeter, maybe pass easily down to the bladder without causing any severe pain or even without causing any complication. And sometimes we have a small stone, just like 5 millim or less than 5 millim, may be obstructed in the ureter. So the size of the stone can predict the future scenario of ureteric colic, but it is not a rule to manage or to intervene with big stone or leaving a small stone, because every ureter is different from other ureter. So our final management is the conservative treatment. And what is the meaning of the conservative treatment? By giving the patient some agents that maybe facilitate expulsion of the stone. We call it the expulsive therapy, ureteric expulsive therapy. First of all, we should give him a painkiller, and the painkiller, as I said, diclofenac injection on need, or even diclofenac tab or capsule can be taken daily. Some antispasmodic agent like Buscopan or Reapal, and nowadays we have with what we call the Drospaz tab or even injection. And also we can give him a certain agent that causing dilatation of the ureter, like alpha blocker, tamsulosin, can be given at a single dose at a night, and especially it's useful for the stone in the lower ureter. This alpha blocker, because it may cause dilatation of the lower ureter and dilatation of the ureteric trapezical ureteric part. And this strategy should be continued for at least 14 days, and we can see that most of the patients with the stone will pass his stone in the urine. Sometimes we have to follow up by ultrasound or even by new CT scan to make sure that the ureter is free from stone. So the final management of the ureteric colic is to follow the conservative rule for up to 2 weeks. The question, if someone asks me how much or how can for how long period we can leave the stone in the ureter. Actually, we most of the authors say that the 2 weeks it's sufficient or it's enough that the stone to pass by itself down to the ureter, or sometimes by expulsive therapy. But after the 2 weeks, it's probably the stone will not pass the ureter. So it's better to be intervened with it. But if I have a stone, maybe here, this or this, in the ureter, and impacting for the long time, in a period more than 4 to 6 weeks, between 4 to 6 weeks, I expect there will be loss of the renal function, even if I intervene later on, but there will be loss of the renal function. Why there will be loss of the renal function? Because when I have an increasing in the pressure of the renal collecting system pressure for a long time, this will cause pressure atrophy on the cortex here. The pressure will transmit it from the collecting system into the renal cortex, and the pressure atrophy on the renal cortex later on will cause cease, or later on will cause decrease in the renal function and even atrophy of the glomeruli. So when I have a stone obstructed for a period more than 4 or more than 6 weeks, I expect there will be loss of the renal function, even if I have intervention later on. If I have intervention by ureteroscope or by double J stent. So never leave a stone in the ureter for more than 1 month, because there will be decrease or there will be loss of some of the renal function. And our strategy of conservative treatment for 2 weeks should be ended between the 2 and the 4th week after the attack, because as I said that after the 2nd week the stone probably when it's still in the aorta, the stone probably will not pass down to the bladder. So what about the contraindication for conservative treatment? We say that the conservative treatment should be made as a rule for every patient with ureteric colic for 2 weeks. But what is the contraindication for the conservative treatment? It means that for whom I should intervene immediately. In the follow-up condition, there is no rule for the conservative treatment. First of all, if I have a single kidney, because if I have a single kidney, it means the other kidney is not present. So when I have a stone in the ureter in the single kidney, there will be anuria, and the patient will become uremic within a few hours, and even in the next day he may need dialysis. So I should intervene in this patient, and I should not leave the stone for conservative treatment. The second condition is when I have even impairment of the renal function. So when I have sometimes the urea may be 80 or 90 and the patient have a stone in one of his kidney, I should intervene immediately, because any delay in the intervention, it may cause also elevation in his blood urea. Maybe for bad luck, maybe I have stone in both ureter, and this also condition may terminate the conservative treatment and proceed immediately to the intervention. And also there is certain jobs that we should also be more aggressive in the management and be more interventive in the management other than the conservative management, like pilots, because this is considered one of the most dangerous job in the world. And suppose that the pilot in his plane or in his craft and he developed a colic, so it should be treated by immediate intervention. And even surgeon and doctor that need more aggressive intervention during management of ureteric colic. نرجع لموضوع الفيفر, because maybe due to long time of obstruction of the ureter, sometimes the patient may develop fever. And why he develop fever? The infection comes from stagnation of the urine and the fluid within the collecting system. This will aggravate, or this will facilitate bacterial growth, and the patient may develop fever, and he may pass into pyelonephrosis. So in the presence of the pus in the collecting system, we call it a pyelonephrosis, which is different from pyelonephritis. Pyelonephritis, it means inflammation of the renal tissue, but pyelonephrosis means that the pus developed in the renal collecting system, which is dangerous and disastrous condition for the patient. And the patient in this condition also need an immediate intervention, and the development of pyelonephrosis will cause the patient will develop high fever, and maybe sign of sepsis will develop for the patient. And in this condition also conservative treatment is contraindicated, and we should intervene immediately. For intervention, we should intervene in the following groups. As I said, first, those who failed to succeed with conservative treatment. It means that the patient lasts more than 2 weeks with his stone and he doesn't pass the stone. And second, those patients who already contraindicated for conservative treatment, like those with single kidney, or those with bilateral obstruction, or pilot, or surgeon, or doctor, as I said. and also those who develop fever due to pyonephrosis. Those 3 groups should be proceeded into the interventive therapy. And we have multiple modalities of intervention in ureteric colic. We will proceed with the simple and non-invasive intervention, which is the extracorporeal shockwave lithotripsy, and may be effective in fragmentation of the stone and relieving obstruction of the kidney. If usual or extracorporeal shockwave lithotripsy is not present or not effective, we should proceed into the more aggressive intervention by sending the patient for preparation for ureterorhinoscope. And the ureterorhinoscope consider one of the golden rule, or one of the best modality for management of ureteric stone. We have 2 types of ureterorhinoscope. We have the rigid type and or semi-rigid type, and the other we have the flexible type. We proceed into the ureter retrogradely through the urethra, and we pass into the ureter, and the stone can be disintegrated with this scope by different mechanism, maybe by laser or pneumatic or electrohydraulic. We have different lithotrite mechanism which is used for disintegration of the stone. Sometimes the patient may be unfit for doing just like major procedure. We put for him a double J stent to relieve ureteric obstruction. But if the patient maybe the stone is bigger than the expected or difficult to be treated by retrograde ureterorhinoscope, we can shift him for open surgery or even for laparoscopic ureterolithotomy. We have 2 types of ureterolithotomy: laparoscopic ureterolithotomy and open ureterolithotomy. So the line of management or intervention with ureteric colic is the following. First, extracorporeal shockwave lithotripsy. If it is not present or failed, we send him for retrograde ureterorhinoscope, which is maybe rigid or flexible. And if this failed, we can send him for ureterolithotomy by open or laparoscopic ureterolithotomy. And those modality actually consider the whole modality for intervention with ureteric stone or ureteric colic. طلبتنا الأعزاء طلبة صف سادس، أتمنى تكونون استفادتوا من المحاضرة. المحاضرة إن شاء الله تكون وافية وكفت وغطت موضوع اليوريتريك كوليك. كنت أتمنى أنه تكونون موجودين قدامنا ونتواصل وياكم فيس تو فيس ويصير التفاعل أكثر، بس لا ضير إذا كان التفاعل عن طريق الكلاس روم، جوجل كلاس روم، أو عن طريق اليوتيوب. ممكن تدخلون نجاوب، تسألون وجاوبكم. بالإضافة إلى هذا أكو عدة فيديوهات موجودة بهاي القناة نفسها على حصات الحالب، قسم من عندها على قص البروستات واستخدام الليزر بحصات الحالب، فممكن أيضا هم تستفادون من الحالة، لأن غالب الفيديوهات هي على اليوريتريك ستون and laser management of the ureteric stone. أتمنى لكم الموفقية وأتمنى لكم حظ طيب، وإن شاء الله يا ربي يبعد عنا هذا الهم وهذا الوباء وهذا البلاء، ونتشاوف ونمتحنكم بأقرب وقت.